Hello, welcome to Nurs 242, Medical and Surgical Conditions of the Newborn and the Child. This course is to equip with knowledge and skills to be able to take care of the newborn, conditions of the newborn and the child. Today we are going to look at birth injuries and birth asphyxia. That is session 1. By the end of this session, students will be able to describe the various birth injuries that can occur in a newborn, discuss the management of the newborn with birth injuries, and describe the management of asphyxia in the newborn. So that is the reading list. We'll start with the first topic, that's trauma to the skin. And we'll look at babies at risk for birth trauma. They are babies who are large in relation to mother's pelvis, preterm babies, breech deliveries, and twins or higher multiples. What are the causes? Usually it's caused by forceps deliveries, vacuum extraction, uterine incision during cesarean section. Types of trauma: we have abrasions, we have bruises, we have punctured wounds, and we have lacerations. How do you manage? You have to do examination of the newborn. The examination should be detailed, and also have to inform parents about the trauma. It has already happened. Don't keep it to yourself. You tell the mother or the parent what actually happened. Then you report every trauma to the doctor. You keep the abrasions and laceration clean and dry. Then antibiotics may be given for infected wounds. So if it becomes infected, you have to use antibiotics. Then if the wound is deep, it needs to be sutured. We'll move on to injury to the superficial tissue. The causes are pressure with reduced venous return. An example is cephalopelvic disproportion. Types of injuries that we usually see are edematous swelling, usually when the baby is presenting with the face or the buttocks. We also see bruises and we also see congestion. And a typical example that we see on the ward is Caput Succedaneum. So how do you manage? What you do is that you reassure parents that the swelling will subside. Usually we don't give treatment unless there is some kind of complication. Let's look at Caput Succedaneum. Caput Succedaneum is a swelling under the scalp and above the periosteum. Causes of caput are excessive molding, when there is excessive molding, when there is cranial compression, when there is occipital posterior position, and head held up on the perineum. It can lead to Caput Succedaneum. So this is an image of Caput Succedaneum. Signs and symptoms include present at birth, cross the suture. Baby may experience some discomfort, but it's usually not painful. But baby may have some discomfort. With time, it tends to grow less, and within 36 hours, it should disappear. A pit on pressure. So this is a baby that the health professional is trying to put pressure on the scalp, and you can see that it's actually pitting on pressure. So how do you manage Caput Succedaneum? You reassure parents that the swelling will disappear completely, and you handle the baby gently. Apart from caput and skin injuries, we have other injuries such as injuries to the genitalia and the buttocks. And this is as a result of breech presentation. All that you have to do is to maintain nappy area hygiene, or apply barrier ointment or cream to the area, or use disposable napkins. We also have face, and this one is also as a result of face presentation. So if the baby is coming with a face and we do VE, if you're not careful, the baby is going to sustain superficial injuries. Another injury that I want us to look at is muscle trauma. Injuries to the muscle result from tearing or when the blood supply is disrupted, and usually causes are tearing of the muscles or blood supply being disrupted. And the most common muscle trauma is torticollis. So let's look at torticollis or right neck. This results from injury to the sternocleidomastoid muscles during birth, when the muscle is torn or its blood supply is impaired. So this is an image of a baby with torticollis or right neck. Causes of torticollis is excessive traction or twisting on delivery of the anterior shoulder with cephalic presentation, or in breech delivery or cesarean section. When there is excessive twisting of the anterior shoulder, it can lead to torticollis. Signs and symptoms include the father is usually present 1 or 2 weeks after delivery, as 1 to 3 centimeters, but it's not painful. You feel a hard lump, then the length of the muzzle is shortened and the neck is twisted to the affected side, as we saw in the image. You managed by teaching caregivers and parents to do muscle stretching exercise of the affected muscle. And this is usually done under the guidance of a physiotherapist. This is done by putting the baby on the unaffected side. Then you encourage mother to move the neck. Usually it takes several weeks to resolve, but if by 1 year and it's not resolved, then surgery may be done. Another injury that newborn usually have is nerve trauma. We are going to look at facial nerve trauma. What are the causes? As associated with forceps delivery, when the facial nerve is compressed, and maybe compression may occur in utero when the facial nerve is compressed during birth. So it can be during forceps delivery or maybe in utero. So this is a baby with facial nerve injury. That's the image, and the signs and symptoms include the eyelid of the affected side remains open. The mouth is usually drawn to the normal side. The baby drools saliva excessively. The baby usually have difficulty in feeding and also in swallowing. How do you manage? There is no specific treatment. What you do is installation of eye drops into the eyeballs. Then feeding difficulties are usually overcome by baby's own adaptation. It can resolve within 7 to 10 days or extend to years if damage is severe. If it happens like that, then it means the baby will need cosmetic surgical intervention. Brachial plexus injury. They are a group of nerves at the apex of the axilla underlying the clavicle. The injury is caused by stretching or disruption of the nerves of the brachial plexus. There are 3 main types. The most common ones are the Palsy, the Klumpke palsy, and the total brachial plexus. So let's look at the causes. It's excessive lateral flexion rotation or traction of the head and the neck during delivery. So as you can see from the image, the midwife trying to deliver the baby. So if there is excessive lateral flexion rotation, it's going to lead to the injury. Also, when shoulder dystocia occurs, it can lead to brachial plexus injury. Let's look at the first plexus injury. That's the Erb's palsy, also known as the Duncham palsy or the waiter's tip. The damage is to the upper brachial pulses involving the 5th and the 6th cervical roots. We'll look at the cervical roots very soon. For this particular injury, the injury is around the 5th and the 6th cervical root. So the signs that the baby usually presents are the following: paralysis of the shoulder and the arm. The baby's affected arm is inwardly rotated. The elbow is extended. The baby cannot flex the arm. The wrist is pronated and flexed, and the hand is partially closed. Klumpke palsy is caused by damage to the 7th and 8th. So here is the 7th and the 8th. The shoulder and the arms are not affected because as the damage is somewhere around the wrist and the fingers. The lower arm and hands are paralyzed, resulting in the wrist drop, and the patient cannot hold things firmly. So this is an image of a patient with Klumpke palsy. The next one is a total brachial plexus palsy. That is complete paralysis of the hand, the shoulders, and arm. There is lack of sensation, and there is also circulatory problem. How do you diagnose brachial pulses injury? X-ray scanning of the clavicle, the arm, and the cervical spine. You can also do assessment of the joint. Then magnetic imaging will also show specific nerve damage at 1 month. How do you manage? By doing passive movement of the joints under the direction of a physiotherapist. Regular follow-up is recommended. Usually there is complete recovery within 6 months. For about 52% of the cases, 2% will not recover and 46% incomplete recovery. Microsurgical nerve repair may be done if after 6 months there is no functional recovery. So what is our duty as nurses? It is the responsibility of the nurse to detect the injury. You also teach parents on how to care for the child after discharge. The range of motion exercise taught by the physiotherapist are well explained and practiced before discharge. Parents must know the extent of damage and purpose of management. Now moving on to hemorrhage due to trauma. The most common is Cephal Haematoma. It's caused by CPD or precipitate labor. It can be caused by vacuum assisted birth. Then it's caused by bleeding that occurs below the periosteum. Is usually present at birth, unlike the caput, which is present at birth. In this case, it is not present at birth. You see it appearing after 12 hours after birth. It's associated with skull fracture in 5 to 10%. Then it tends to grow larger over time and does not pit on pressure, as in the case of Caput Succedaneum. So this is a patient with Cephal Haematoma. It doesn't pit on pressure. Management. You reassure parents that the swelling will disappear completely when the blood is reabsorbed. Then transfusion and phototherapy may be necessary if blood accumulation is significant, because one of the complications is jaundice. So when it happens, then photo is indicated. Birth asphyxia or asphyxia neonatal. What is asphyxia neonatal? Is an insult to the fetus or newborn due to lack of oxygen and lack of perfusion to various organs. The causes are obstruction of the airway by mucus, by blood, by liquor, or by meconium. Any obstruction of the airway can lead to asphyxia neonatal. So this is a baby with asphyxia. So when they grow, this is how they look like. Maternal risk factors, we have a lot. Some of them are premature prolonged rupture of the membranes. When the mother bleeds in the second or third trimester, it can actually lead to the child having birth asphyxia. When the mother abuses drugs, when the mother has DM, when there's chronic illness, and so on and so forth, it can lead to the child having birth asphyxia. Fetal risk, when there's multiple pregnancy, when the baby or the newborn is a preterm or postterm, it can lead to the baby having birth asphyxia. And after birth, when there is severe hemorrhage, can also put the baby at risk. And the target organs of asphyxia are the brain, the heart, the lungs, the kidney, the liver, the bowel, and the bone marrow. We'll look at the classification of birth asphyxia. The first one is no depression. That means that the baby is safe when the Apgar score is 7 to 10. But when it's moderately depressed, Apgar score is about 4 to 6, and when it's severe, Apgar score is 0 to 3. But there are a few exceptional cases. For example, a low Apgar score may not indicate asphyxia in a preterm or small for gestational age. Usually, these babies have low Apgar score. Also, infants below 30 weeks gestation often have an Apgar score of 2 to 3 without asphyxia. The clinical manifestation that you see in a baby who is having asphyxia are the following. They have fetal bradycardia, the failure to breathe spontaneously, there is pallor, there is cyanosis, there is apnea, there is seizures, the cord feels flappy, the apex beat is low, irregular, and weak, and there is also poor muscle tone. So in the absence of respiratory efforts, resuscitation measures are started. You should make sure that the equipment are always available. You don't wait till you check the Apgar score and you rush to look for the equipment. So what do? You stimulate by gently drying the baby. You provide warmth, you cover the baby, you clear the airway, and we know how to clear airway. You suction, breathe in. You also make sure there is ventilation and oxygenation, circulation, ensure effective circulation, and drugs. You can also give prescribed drugs. Let's now look at harmful and ineffective resuscitation practices. Sometimes the midwives tend to squeeze the chest to remove secretions from the airway. It shouldn't be done. Then routine giving of sodium bicarbonate to newborn who are not breathing. Then intubation by unskilled people. Intubation should be done by very skilled health professionals. Then some traditional practices, they put alcohol in the newborn's nose. They sprinkle or soak newborn with cold water. It shouldn't be done. The baby can actually go into hypothermia. They stimulate the anus. They slap the newborn. They also turn the baby upside down. Complications of asphyxia. We have neonatal seizures. We have cerebral edema, renal failure, the cardiac failure. We have neck. We have long-term, which is cerebral palsy, deafness, epilepsy, and so on. So you are supposed to read on fractures in neonates. Today we have been looking at birth injuries and asphyxia. We have looked at trauma to the skin, other injuries, injuries to superficial tissues, muscle trauma, nerve injury, hemorrhage due to trauma, and birth asphyxia. Thank you.